Sleep accounts for 1/3 the time that you're alive. It's essential for health. It restores the brain. It improves thinking. However, we're not really where we want to be. The Sleep in America poll was done in 2010, and it looked at how satisfied people were and how they were doing with their sleep. 4 in 10 respondents of each group said they get a good night's sleep every night or almost every night, but that was only 4 in 10. So let's talk about why this might be. First of all, sleep is under the control of the brain. It's not just a brain shutdown. It's an active process. The brain has a 24-hour clock that basically determines whether you're asleep or awake. That's located in the suprachiasmatic nucleus. This is the pineal gland. It responds to light and tends to synchronize the suprachiasmatic nucleus here. But this is the basic clock of the brain. In addition, there's a clock inside that clock. When you sleep, you go through a sequence of stages that we now call stage 1, stage 2, and stage 3 in REM sleep. And these cycles repeat during the course of a night, with the black bar being REM or dreaming sleep, and stage 1, 2, or 3 going down. This is a little bit outdated plot that has stage 4, which has since been merged for classification purposes into stage 3. Slow wave sleep is the part of sleep that appears to recharge the brain. It apparently, the reason we dream is to allow us to go back into slow wave sleep. And what slow wave sleep is called slow wave sleep because you have these brain waves that are in the low frequency range, like 2 or 3 cycles per second, much less than the frequency that you have while you're awake, which is 8 to 12 hertz frequency. Learning, in fact, depends on having enough slow wave or REM sleep. These are this is a graph. These are actually from rat learning, but it's about the same in people. And you can show there's more learning, the more dreaming sleep or the more slow wave sleep you have. The greater percentage of the total night, the better you learn. So apparently brain function really needs sleep. How much sleep do you need? It depends on how old you are. When you're very young, you need quite a bit. As you get older, you need less. So we go to about half the requirement of an infant at 14 hours by the time we're in our 7th decade. Animals vary quite a bit more. Predators sleep a whole lot, like lions, but animals which are grazers, they don't sleep very much. Other animals have adapted a lot of modifications to their sleeping so that they stay alive. Birds sleep with one eye open and remain vigilant. And manatees and dolphins sleep with half their brain on and half off so that they can surface and breathe. These are manatees in Florida under the water, and they come up every few minutes to breathe. But their brain, they switch sides in their brain. What happens if you don't get enough sleep? Well, there's 2 kinds of paradigms. One is complete sleep loss, which is kind of hard to do to people, and the other is partial sleep loss. In animals, complete sleep loss can be fatal, but it's very difficult, obviously, to see this happening to people every day. People are going to fall asleep, but maybe not in bed if they're sleep deprived. Chronic sleep loss can cause decreased quality of life, memory problems, fatigue, depression. A lot of medical conditions are increased in severity, like stroke, diabetes, heart disease. And obviously people have more accidents. And one of the reasons they have accidents is even though you don't sleep at home in your bed, you start sleeping for a few seconds at a time, and things like this can happen. And it turns out in the Ukraine a number of years ago, the world's worst nuclear accident was embarked upon in part because there were some sleep-deprived people. Otherwise well-trained operators made some judgment mistakes and blew the thing up. Apparently this wasn't quite the case in Japan. That was more of a natural disaster. But the management after it, one wonders. So why can't people sleep? What keeps us from sleeping when it's such a good thing to do? Well, insomnia. This is what we call, obviously, not sleeping. Basically, the brain fails to shut down. And there can be a lot of reasons for this. But one of the main reasons that I like to discuss with patients is that if you look at the brain, and this is a cross-cut through the brain, there are all these nerve cell centers, and these are locus ceruleus, the raphe, the tuberum, mammillary nucleus, and other areas that each have a turning on function. There's actually 4 or 5 well-recognized brain turning on centers, and there's one or two brain turning off centers, the ventrolateral preoptic area. But it turns out that in order for your brain to sleep, everything together has to shut down. And for various reasons, people don't do this. And if you look at the metabolism in insomniacs in their brains with PET scans or other techniques, their brains are just continuously active, which is pretty much what they're telling us. There is some degree of genetic contribution here, and certainly habits and medications are a factor. In terms of, and I think here's a good quote from Mark Twain, who it turns out had a lot of good quotes about sleep, had a lot of good quotes about sleep. I hate a man who goes to sleep at once. There's a sort of indefinable something about it which is not exactly an insult, and so on. But if you look in the quote websites, you can find a lot of good sleep quotes by Mark Twain. Medications, a lot of them cause sleep disruption. Some are stimulants, some disrupt sleep in other ways. Some of the antidepressants are sedating, but the newer ones are all stimulating and shouldn't be taken at night. Some of the anti-seizure medicines disrupt sleep by mechanisms that aren't quite sure. A lot of medications are stimulants like decongestants and, of course, stimulants. Thyroid and certain blood pressure medicines can also have this property. So, you know, if a person has insomnia, sometimes it's pretty simple. They're just taking a medication. A lot of people will take an antidepressant at night that should be taken in the morning. And when we treat insomnia, one of the things we're dealing with is the fact that you sort of make your bed and you sleep in it. As you make your bed, so you must lie in it. And sleep hygiene is this whole series of recommendations about conditioning yourself to sleep. Of course, we also use medications and behavioral techniques, but sleep hygiene is the first step. And I'd like to show you these 2 little videos that show the extent to which sleep behavior is learned. This is our parrot, Jack. And he wants to go to bed, and he just said, night, night. You can hear this again. Here we go. That's night, night. He's learned to say night, night. In the morning, when he gets up, he says, good morning. So a lot of what we do basically, and it is very, very strongly motivated to do these, does them every morning. We have a lot of habit about what we do. And the sleep hygiene recommendations, the sleep hygiene recommendations basically are learning how to organize your sleep schedule. First of all, have a sleep schedule. I can't tell you how many college students, particularly young women, who do things like waiting tables to make extra money and think they can work like they can work from 10 to 3 a.m. on one night and then have a regular class schedule the next day and then 2 other schedules the rest of the week. You have to have a regular sleep schedule. Also important is having early exposure to outdoor light. Now you can get light boxes and things that are with these high intensity light emitting diodes, and those are quite nice for synchronizing to the light. Avoid stimulants and excitement towards the end of the day. have a relaxing bedtime routine, reduce alcohol, get regular exercise, though usually early in the day for most people, and have the largest meal at the end of the day. And you can find a list of these on WebMD or any other reasonable medical website. Of course, modern life equals inadequate sleep. We sleep 1.5 hours less than our ancestors because of travel, electric lights, shift work, computers. And we have the idea that we can negotiate with sleep, that sleep is wasted time, that it is not macho or cool. But you can't always get what you want. You have to kind of listen to the biology. You need sleep. Now, the other thing about sleep is that there's a cycle to your sleep, and that this cycle affects a lot of things. So proper sleep also has a lot to do with immunity and health. And it turns out during the day, timing is everything. At different times of day, there are different resistances to infection. It turns out that vaccines are most effective early in the day, and that the immune response is most effective early in the day. Strokes and heart attacks, it turns out, also tend to happen in the early morning hours. Acid secretion and peaks in the around midnight. And all these are very, if you have reflux, this is one reason that your sleep may be disrupted. So it's important to realize that a regular daytime schedule affects a lot of body functions. Infection and fatigue are very closely related, because when the body is the target of an infection or inflammation, all these molecules are released by your immune system, interleukins, tumor necrosis factor, and it turns out they all tend to alter your sleep pattern, and they alter the stages of sleep. They go right to those nuclei in the brain, and they alter the balance between REM sleep and slow-wave sleep, and can have a very powerful effect on the effectiveness of your sleep. Sleep apnea. I think, in contrast to insomnia, sleep apnea is often not recognized by patients. They often don't come in complaining of it. 1 in 15 adults has moderate to severe sleep apnea. This is in contemporary America. 9% of women and 24% of middle-aged men. 85% of patients with sleep apnea remain to be diagnosed. The prevalence is increased in various medical conditions. In patients with poorly controlled high blood pressure, 80% will have sleep apnea. And if either of the high blood pressure or sleep apnea are controlled, it helps the other problem. Obesity, congestive heart failure, heart atrial fibrillation, diabetes, all very high percentages. Now, sleep apnea occurs because your upper airway is a multifunction passage. You talk through it, you breathe through it, you eat through it. It's highly programmable, if you will. And without the brain telling it to remain open, it doesn't necessarily remain open. So typically the area of concern is right down here. And I have a pair of MRI scans on the next slide. This shows a typical non-obese patient who is not a patient, it's just a person who doesn't have sleep apnea. And this is a patient with sleep apnea. Note the extra fat around the neck, the 18 plus inch circumference. Here's the larger tongue and the narrower space through which air has to flow. This is the trachea here. And this is the area that gets impinged on, particularly when the person's lying down, face up. The tongue just has to slide back a very little bit. And when that happens, you can get music of a sort, snoring, because air flowing past the palate will cause the palate to vibrate, and this is snoring, which, as you know, can be quite loud. And it can also cause things to completely stop with complete cessation of airflow. And this is sleep apnea. Now, typically a patient just doesn't have one apneic spell. They have many in the course of a night. And what we do is we measure these by hooking a patient, and this is probably a volunteer here. He's wearing belts that measure breathing. He's wearing some little wires around the nose that measure airflow. He's got muscle action detection on the chin. He's wearing brainwave detectors, and he has some electrodes near the eye that measure eye movements. All these things are important to look at sleep. And what we get is called a polysomnogram. And here we have, this is a typical polysomnogram. It shows eye movements up here. It shows chin, EMG or muscle activity. It shows brain waves, heart signal, EKG. And this is muscle action in the legs. And then we have oxygen flow measured in various ways. And we have movements of the chest and abdomen measured with belts that stretch and give an electrical signal. So this is normal sleep. The whole page is 10 seconds long. Actually, no, it's 30 seconds long. And each one of these ticks is one heartbeat. And each one of these is one breath. Actually, 1 minute for this page. So each one of these is one breath. And it's regular, the air is moving regularly, the chest is breathing regularly, everything is fine. Now, in the case of sleep apnea, what happens is a little bit more chaotic. One thing this is 2 minutes for this page. What you see here is the airflow is moving here, but stops for periods. And during these periods which are stopped, you see ever greater movements as the person tries to force air through. And then you get a gasp, a large amount of air moving, and probably a snore. This is, I don't think there's a microphone. There's a microphone channel right here. So this is showing a snore. This is a microphone showing the snore. And so you're getting an apnea here. And in the course of 2 minutes, we're seeing basically 4 apnea-type periods. Also, the heart rate you can see is quite fast here. And this is such a stress on the body that it raises your heart rate, which in turn raises your blood pressure, which gives you hypertension, actually, that lasts during the day. So that's a typical obstructive sleep apnea. When people have this, you can kind of guess the consequences. They're tired, they're fatigued, they fall asleep without trying. They've had these apneas at night. Turns out they have more frequent trips to the bathroom because this stimulation, due to the apnea, it tends to stimulate the kidneys. They have more problems with mood. Men will have more frequent problems with impotence. They'll have dry mouth because of the difficulty in breathing. With secretions, morning headaches are more common. Blood pressure will be elevated. Lots of problems. People are less productive when they don't get good sleep. And here's the snorer, and here's Mrs. trying countermeasures so that she can sleep. Now, the thing about obstructive sleep apnea is that if your spouse is sleeping very soundly, you may not know about it. A lot of times the people are sometimes living alone, but having history from a family member, sometimes family members go to the opposite side of the house, not even the same room. When we see these patients, we look at their medical problems. If you're taking a sedative, that could make your airway collapse more, or drinking, smoking, other medications, it's important to look at these. We examine the patient, look at the structure of the airway. We look at their nostrils. We look at their neck diameter. Examine their heart, see whether there's signs of heart disease, and unless we can find an easy explanation, it's probably necessary to do a polysomnogram, and we usually do these at centers where there's national accreditation, like by the Joint Commission or the American Association of Sleep Medicine. There are a number of ways of treating sleep apnea once you diagnose it. Just to go over these, we have oral appliances, surgery, and then the breathing machines, CPAP and BiPAP and so on, lifestyle changes, sleeping position. oral appliances, just to show you what they look like. There are devices like this that are non-prescription, but this is a precision constructed one that actually advances the lower jaw out to remove the obstruction at the back of the throat. And the way they do this is if you can move your jaw out, you can lift this up and prevent that obstruction that you saw before. They're useful in patients who have snoring or sleep apnea. They can cause discomfort because you're putting stress on the temporomandibular joint, which is the joint of your jaw to the rest of the skull. And you can have trouble handling saliva. The biggest problem is that they're not that effective, 30 or 40%, but they're useful in patients who can't tolerate CPAP. Surgery, the thing about surgery is that, of course, once you buy it, you can't return it to the store. So a uvulopalatopharyngoplasty works by getting rid of this vibrating uvula and removing tonsils and so on. And this opens up the back of the throat and makes snoring less likely, but it can cause problems with handling secretions. And actually, with this very long incision in a very sensitive ear, it can be quite painful. So we don't usually resort to this unless other techniques fail to work. There are other procedures, such as moving the tongue forward by working with the lower jaw, or actually moving the whole face forward with, as you can see here, moving the upper mandible. And you get these at Home Depot. No, actually you don't. They're made in Germany, probably out of titanium. But in all seriousness, this is reserved for kind of resistant cases. But these are kind of big deal operations, a large incision, but they can be effective. But the overall success rate of these procedures is not that high. And of course, we want to fix this. And of course, the most common solution that we use is CPAP. Now, CPAP stands for continuous positive airway pressure, and there are variants called BiPAP, where you have different inspiration and expiration pressures, and ASV, where you have automatic breathing if you're not breathing like you should, which is useful in some heart failure patients that have problems initiating breathing. And of course, the good thing about CPAP, although it does look funny, is that you can take it off. And there are many different kinds of masks. This particular mask here is, I think, not a common look. It's a nasal mask, which is the most kind, but the actual headgear is a little unusual. But there are many kinds of masks. Some just fit under the nose, some fit over the nose and mouth, and there are a lot of choices. Success with CPAP, a lot of it depends on training a person how to wear the mask, how to adjust it, what to expect. If there's a problem with adjusting to the pressure, setting it up with a gradual ramp pressure, sometimes dropping the pressure for a few weeks. Some patients require medication to deal with claustrophobia issues. One problem we run into is that some of the insurance companies would like to just drop ship someone a CPAP unit from Central Supply with a videotape, and it's not really as effective as working with a trained technician. So it's important to have, if you get one of these units, it's important to go back to your doctor or the technician who manages it and look for solutions. There's a lot of potential solutions. There are other sleep conditions. Restless legs. Restless legs and periodic limb movements are two almost interchangeable things. Restless legs are what people feel while they're awake, and periodic leg movements are the kind of correlate during sleep. But typically a person has an uncomfortable sensation that builds, and then they move their leg, and it feels better. They happen at night when you're in bed, or if people are inactive during the day. These are treated, skipped a slide here. Yeah, we've lost a slide. But anyhow, they're treated with medicines that increase dopamine. Similar to Parkinson's medicines, some of the anti-seizure medicines can work. Some pain medications occasionally. And some patients require a treatment all through the day to get rid of restless legs and disruption during night. But these movements can significantly disrupt sleep and cause patients not to get effective sleep. Sleep changes as we age. Nighttime sleep is more likely to be disturbed as we get older. And of course, people as they get older have more medical conditions that mess up sleep. And older people, particularly when you're not working, tend to have sort of free running sleep schedules that allow them to sleep and be active at any time of the day. And this adds further challenge to managing sleep. Men in particular have less deep sleep as they get older. It takes longer to fall asleep as people get older. And the reasons for this have to do with the aging of the brain. There's certain hormones like growth hormone and melatonin which are a little less abundant. There's less, the older you are, the less likely you are to get outside and have variations in the light your body's experiencing. Less exercise is another factor. However, and then as we get older, many people take more trips to the bathroom. Also, many healthy elder patients, despite all this, continue to sleep well. When should you see your doctor about a sleep problem? When sleep limits the activities of daily life. Insomnia or daytime sleepiness is really not normal, and it's important to work on it with your doctor, although the solution may not be a pill. You may need to see a sleep-trained specialist. However, many people become resigned to having poor sleep. A number of medical problems affect sleep. Arthritis, heartburn, cancer, Parkinson's disease has a very powerful effect. Breathing problems including COPD, heart failure, peripheral vascular disease, and fibromyalgia. Any pain tends to disrupt sleep, which is not too surprising, but fibromyalgia has a very interesting effect. In fibromyalgia patients, you actually have less restorative slow-wave sleep, and the slow-wave sleep that they have tends to have a lot of features of waking sleep, specifically alpha rhythm intruding into sleep. And if patients have successfully treated fibromyalgia, they get less of this. So there's something that happens to the brain as a result of this body problem of fibromyalgia. Menopause is associated with an increase in sleep apnea. This might have to do with the breathing stimulatory effect of the female hormones, which drop after menopause. And there's, because of this, more daytime fatigue and sleepiness with menopause. Epilepsy. There's a very strong effect of sleep on seizures. Some types of seizures occur more often in sleep, and some seizures are very sensitive to sleep deprivation. Seizures that originate in the occipital lobe, or the back of the brain where vision is processed, tend to be less common at night. But seizures that originate in the frontal lobe, many of them are more common at night, and many of them are very unusual in their manifestations. People vary in their tendency of sleeping, of course. We talk about larks and owls. This gets us into the concept of sleep cycle disorders. Advanced sleep phase syndrome is when you're early to bed and early to rise. And this is the lark phenotype. People like this tend to be perfectionists. Delayed sleep phase syndrome is when you're late to go to bed and you wake up late. And very commonly, in fact, I saw someone in the office today had this problem. Terrible procrastinator, very characteristic of personality. Of course, if you're retired, it probably doesn't matter to some people, but it can be an issue. We now treat with melatonin and light boxes, and this is a whole other talk. We can treat these conditions, and like I say, we have all these wonderful devices now with these LEDs, the white LEDs that simulate natural light and don't. And this contrasts with you go back 20 years ago, there were banks of fluorescent lights weighing hundreds of pounds, costing hundreds of dollars. Now it's a cheap item, so it's much nicer. Sleep and dementia. Alzheimer's disease is associated, and aging is associated with a greater difficulty in training the sleep rhythm with natural daylight. And one of the problems you see in Alzheimer's patients is a failure to sleep at night and a failure to have normal decreased activity. Medications which affect sleep. We've talked about some of these, but antidepressants, Valium-like drugs like benzodiazepines, sleep, antihypertensive drugs can have big effects. Thyroid medicines tend to wake people up. Prednisone, steroids like prednisone normally are secreted in a pulse that is greatest in the morning. And this is how they appear in the body, and it declines during the day. When you take prednisone, and you take a lot, and you take it all day long, it messes up your sleep cycle because your body wants to see something different. Caffeine and nicotine are stimulants. Many patients with sleep problems have to be educated to get completely off of caffeine or not to have any caffeine beyond lunchtime, perhaps, if they're lucky. Conclusions. Sleeping enough and sleeping well are essential to medical and physical health at any age. Having the right lifestyle is more important than medication for good sleep. And patients should see a physician with sleep training if they continue to have problems, say after following sleep hygiene recommendations. So that's my prepared talk. And if any of you have questions, if you want to if you have any further questions, here's an important note. We have a sleep lab here at the hospital, and you can contact the sleep lab, and I think the numbers are up front if you have questions about sleep studies or sleep problems, and you can contact me in my office. Any questions from the audience? Yes?
Yeah, I have two questions. One thing you hear a lot, I've heard a lot recently in the news and stuff, is that the earlier you go to sleep, meaning like before midnight, the better quality sleep you get. Is there any truth to that? Like if you go to bed at 10 o'clock as opposed to going to bed at 11:30 or 12 o'clock?
Well, if you have a typical sleep cycle, it's probably better, but it depends on your internal sleep rhythm, what it's set at. So many people have different schedules, and that's okay. But if you have, delayed sleep phase syndrome, and you go to bed at 9, you're just going to sit in bed doing nothing and getting frustrated. If you want to shift that, you have to go through changes in behavior that are stepped gradually by maybe 15 minutes, or sometimes delaying your bedtime 15 minutes every night till you rotate your cycle. Of course, that means you're on an inverted schedule for a few days, but the best way to to shift your sleep schedule is by delaying. It's hard to advance. But you want to sleep where your clock is set to.
So it really doesn't matter for people then?
No, you could.
Get a better quality of sleep.
I don't think so, no.
I have another question. My husband, he doesn't have the leg syndrome, but he, at all different times, because I've been awake at different times of night, I noticed it, his whole body can jerk, or his whole, an arm or whatever. And I mean, pretty substantial. I know you have a little bit of that when you first fall asleep.
That's right.
You're having your body straining. But this can happen at different times during the night. Is there a particular reason that causes that?
Well, when you go to sleep, and particularly when you enter into REM sleep, which is dreaming, your brain actually is functioning as if you're awake, but there's a switch in the brain called the nucleus magnocellularis. A nucleus, for neuroscientists, is just a name of a bunch of nerve cells together. And what that does is it turns off the connections to the rest of the body such that you don't actually run when you're dreaming about running. Unless, of course, you have REM behavior disorder, in which case that switch isn't working. So he could have possibly REM behavior disorder, and a couple other conditions, depending on the timing of the night. There are also other kinds of jerking movements that people can have. that require different treatment than restless legs. Restless legs is the most common and tends to be repetitive and has a periodicity of like between of movements of the legs that occur every 5 to 25 seconds. They're not just random. And it tends to disrupt sleep more. There are certainly other kinds of movements, though. Yes, sir?
Yes, sir. Is there any way to reduce or alleviate the time zone change, traveling through different time zones? Prepare for it?
Yeah, there are.
Usually the worse it gets.
There are schemes for taking melatonin and adjusting your wake and sleep times before you leave to minimize disruption. Generally, flying west is less disruptive than flying east. It has to do with the degree at which you shift your sleep schedule. Generally, it's easier to delay you can very painlessly delay your sleep cycle by 3 or 4 hours at once. You can use melatonin to induce sleep, and it's also possible to use various stimulant and sedative medications. The trick is how to do that and not make yourself, stupid if you're conducting business or something like that in a foreign country. But there are ways to do it. It gets tricky, though, if you're talking about shifting about 12 hours, because you can get contrary effects, very contrary effects. So that's when you need to sit down and learn and carefully map out where your cycle is and where you're going and work out with a sleep specialist how you're going to do that. Yeah. Yes, sir.
With REM sleep,
Yeah.
do you always have dreaming with REM sleep, or can you have REM sleep without dreaming?
Well, the typical dreaming is associated with REM sleep, but usually the dreams aren't recalled, and so there's a certain kind of ascertainment problem there. You can't talk to a person after they sleep and realistically expect them to tell you what happened. But in research studies, when people are woken up, when they have the wires on, they wake up, hey, what's going on in your head? And they say, I was dreaming about this. And it turns out that there are actually circuits that turn off the memory. Your data logger is turned off when that happens. So that may answer your question. Sir? Well, the time of day at which you take them is important. So you need to work with your endocrinologist about the time of day you take it. But thyroid hormone is highest level in the morning. But there are other things about hormone supplements which we can't really handle yet. And one of those is that the hormones are typically released in pulses by the normal endocrine glands, and our drugs don't do that. There's a huge slug taken once a day. So you need to work with your endocrinologist about the specific situation. But there can be challenges, obviously, with the timing of the medication. Anyone else? Yes, ma'am, in the yellow.
If you are not sleeping well at night, the naps during the day count?
Oh, yes. The naps count, and you have to get rid of your naps if you're going to consolidate your sleep at night. If a person doesn't have a daily schedule, like a job or something, that keeps them active, this can be a challenge. A lot of times people don't really log what they're doing. In the back, in the green, ma'am?
Oh, yes, I actually have sort of a two-part question.
Yeah.
One is, what are some of the causes of waking up multiple times a night? Like, I don't feel like I sleep deeply, and then I wake up anywhere from 6 to 12 times a night. And when I do, I never seem to be dreaming. I never feel like I've dreamt in years.
Yeah, well, it turns out that in non-REM sleep, there's also mental imagery. And this has been recognized in the last 10 years, that dreaming isn't only restricted to REM sleep. People the type of mental imagery that occurs in non-REM sleep is not very detailed, but can be kind of threatening. Like if a person is woken up and you talk to them, they'll say something like, "I was being attacked." No other details. It's a kind of vague thing, a lot of emotion with it. Sometimes people can have mental imagery that disrupts their sleep. People can have panic attacks at night that can wake them up. Patients who have depression frequently wake up in the early morning and have their minds completely awake, and this requires modification of their treatment. But there's a failure to shut down the brain associated with this. Seizures can occur at night and disrupt sleep. Reflux and asthma can become more severe at night. Certain pain conditions can do that. In a lot of cases, we're not really sure, and we have to look at clues and try different things. Any other questions? Hey, ma'am in the white?
Is there a danger in taking the over-the-counter sleep aids on a regular basis?
The over-the-counter sleep aids are, they're to some extent anachronisms, because I think if they were tested in the current day, they wouldn't be approved. I don't know if you've been following the news, but a lot of medicines that have been traditionally used have been dissed by the FDA. Quinine is the big one. Quinine caused really bad heart and immune system problems in a small number of people and was killing a few people every year. And now if you have restless legs, it used to be great. But the problem is there were actually people dying because of the quinine, and it was taken off the market. The sleep aids, the most common one is Benadryl, which is a sedating antihistamine. The problem with Benadryl is it has a long hangover. Once in a while it's probably okay, but Benadryl is has some anticholinergic properties, and as you get older, what makes Alzheimer's and memory problems is less cholinergic function in the brain. So there could be problems with cognition, and this has been one of the motivations for getting the newer antihistamines, which aren't so sedating, on the market, because with people taking these and driving cars, it's a little frightening to think when you have 100,000 cars on the road with people taking sedating cold meds, and which are known to cause problems in reaction time and thinking. So that's one problem. Melatonin is sold over the counter, and it is useful. It's a synthetic drug. It's not natural melatonin, which is probably good, because natural melatonin would have to be extracted from brains, and there'd be questions of things like mad cow disease or Jakob-Creutzfeldt, which are not good. And so it's good that it's synthetic, but it's not regulated by the FDA. And there were certain dietary supplements like tryptophan a few years ago, which was produced by a Japanese company, and a batch of it caused some fatal illness because there were contaminants. So these are not as regulated, so there are some issues with melatonin. There's a drug that imitates melatonin called Rameltian or Rosarum. It was the drug that had those commercials with Abe Lincoln and the beaver. I still can't figure out why they did that. But it was a good idea for a drug, but it has a rather subtle effect on sleep and is completely unsuccessful in the marketplace, and very few patients are on it for various reasons.
When I take them, one, I'll have a good night's sleep
Mhm.
without a hangover the next morning, and then the next night there's no sleep to be had.
With the same medicine?
No, if I don't take it, even if I don't take it, I can't
Oh.
sleep. I'm wide awake all night. So I trade one for the other.
I can't comment on that. It's an interesting observation. I'd like to make an intelligent comment. I can't. It's interesting. Any other questions?
If you take a baby aspirin, I take mine at night, but does it matter when you take that?
It might, but I don't know. I'd have to look that up. I wouldn't be surprised. There's a huge amount of information coming out every month on this. The information on vaccines is particularly interesting. It turns out there's a huge difference in the effect of vaccines. and also in the effect of if you give someone an injection of bacterial products that would normally cause fever, the reaction of the body varies completely different over the course of a day. So there's definite times to get vaccinated if your intent is to get a benefit from the vaccine, and so on. Well, if I appreciate all you coming, and if you have any questions, take one of my cards and give me a call. It's very nice to see this degree of interest in sleep conditions. Thank you all.